Awesome. All right. Why don't you talk a little bit about the echo real quick, Dr. Tam, and then Dr. or Dr.
Great.
Albert, either one.
I guess, yeah, I'll start with the ECHO program real quick. I want to say thank you to everybody for coming. The ECHO program is pretty cool. It's like Teams on steroids in a lot of ways, but in reality, it was developed by University of New Mexico as a way to help teach and to share knowledge. They call it like a hub and spoke model where you develop hubs and then extend knowledge out to different people. So we're going to try to record this and try to, expand information sharing and how to take care of people. Basically, it focuses more around medical care, really. And I always wondered why it was called ECHO, which they don't really make prominent, but it stands for the Extension for Community Healthcare Outcomes. So that's kind of where the name came from. So we've been working on this, and I'll hand it over to you guys again, Dr. Tam, Dr. Anzalone.
Yeah, so I'll listen. This whole program has been developed because of a need for us to be able to share information. One of the areas that we found gaps in our education was in behavioral health. There's disparity in terms of providers prescribing and also knowledge base in terms of dealing with behavioral health, in terms of medications, in terms of how to use medications, when to use medications, how to use it. So we had the hotline that was offered to us, which we're going to continue to promote. So on that hotline is Dr. Saundra Stock's team from the University of South Florida. Dr. Stock is our first presenter. She's actually our inaugural presenter for our first meeting on ECHO. This is going to be piloted and most likely be the model for how not only are we going to be educating our group here, but also throughout the state of Florida eventually. Assuming we are grant recipients, we have a lot of work ahead of us in the next 5 years. So this is part of this whole process of disseminating education, giving us platforms to be able to share information, case presentation, and strengthen each other. I do recommend that those of you who are participating in ECHO through our free CME, through the Boston Children's program, go through that primer, 5-hour primer regarding managing childhood and adolescence in terms of anxiety, depression, mood dysregulation, as well as ADHD management. And then the toolkits that are also being provided within the offices, both in English, Spanish, as well as Creole, I think most recently. Is that correct, Dr. Tam? I think Creole Creole got translated. So a little background about Dr. Stock. She's the Associate Program Director in Child and Adolescent Psychiatry, Behavioral Neuroscience at the University of South Florida. She's the Chief Division she's the boss, the department chair, chief division director of the Child and Adolescent Psychiatry and Behavioral Neuroscience at USF, and also has been gracious enough to be able to share her expertise with us. So you might, from time to time, when you call that 1-800 number at USF hotline, is get her on the phone or her colleagues. So without further ado, I don't want to take up much time because we have a lot to cover here. Dr. Stock, if you don't mind. Appreciate you showing up here today and sharing with us.
Great. Thanks for having me. So I'm going to talk a little bit about ADHD, the agenda today, just some basics about ADHD. We'll have some time to talk about cases, and then I think, are hoping to have some other sessions where we'll talk about some more complicated cases. So just, we're not going to go through all these slides today. We'll go through some of them. So what is ADHD, right? You all know it's, symptoms of inattention and or hyperactivity, impulsivity. They're present for at least 6 months in 2 or more settings. The symptoms should be present by age 12. They're not always impairing by age 12 based on if the environment is really supporting the kid. You may not be seeing the impairment, but sometimes when you ask, you'll realize that people were naturally supporting the kid. The symptoms should be not developmentally appropriate, and the symptoms are maladaptive, causing impairment in social and academic and occupational functioning, depending on the age of the kid. We talk about ADHD, really, we talk about like trouble focusing and fidgeting. That's like the tip of the iceberg, but there are lots and lots of problems that people who have ADHD, lots of things that they suffer with, right? So a lot of times parents will ask like, well, so like my kid can pay attention to video games, and he can do what he wants, but how could he have trouble? He's only having trouble paying attention, in school or in things he doesn't like. And that is true. ADHD is not a deficit of attention. It's a deficit in regulating your attention, or it's a difficulty in regulating it. So people have a hard time placing their attention and focus on things that they don't inherently like. So they may do just fine with things that they do enjoy. And there's lots of things that may be underneath this in terms of like difficulties with relationships, difficulties, having conversations, having friendships, trouble with memory, trouble sometimes with sensory issues. About a third of kids with ADHD have really intense moods, so they have really high highs and really low lows. So people talk about this rejection sensitivity dysphoria, where they're very easily dejected, and just like kind of mood swings, all sorts of different things, choice paralysis, things like this. So lots of different things that are actually not in the criteria, but that families notice. And it may be more focused on one of those than the traditional criteria. Prevalence rates are around 5 to 10% of school-aged kids. Traditionally, we've said that half of people grow out of it. So when they do large studies like of the population where they ask people all the symptoms of the DSM disorders, if you just go out broadly and survey the population, 4% of adults will screen positive for ADHD. So that means about half of people outgrow it, but 4% of adults will continue to meet criteria for it. And at least half of those adults have traditionally been taking stimulant medication, although we now see that many more people are taking medications these days. ADHD is associated with prematurity. The more premature you are, the more likely you are to have ADHD. So, sometimes kids are very premature. We focus on their motor milestones and things. A lot of times they're caught up by age 2. But when they get into school, you're going to see that they may have difficulties with attention and focus. Same thing with low birth weight. If a kid is below normal birth weight, stronger chance of having ADHD. And if they were exposed to cigarette smoke in pregnancy, that's a higher chance of ADHD. Male to female ratios usually talked about as 3 to 1. Girls tend to be more inattentive, so girls often fly under the radar more until like middle school or high school because they're just not jumping all over the place causing trouble. It's strongly genetic, about a 70% concordance rate going from fathers to sons. There are several genes that are very highly consistently transmitted. So there's an abnormality in the dopamine uptake transporter, the DAT1 transporter, and in the dopamine 4 receptor. So those two dopamine abnormalities are highly passed on. And so those females are often a little less hyperactive, more inattentive. So what happens with time? People who have ADHD, when parents are like, well, they'll grow out of it, and they may, or ask what happens, people who have ADHD have lower rates of high school graduation, lower rates of college degree attainment, higher rates of substance use. So substance use is about 15% of the adult population. Somebody who has ADHD, it's higher percent. If you have a pool of ADHD patients, they're going to have a higher rate of substance use. And typically we see that if they have gotten treatment for their ADHD, it's closer to the norm, probably still a little bit elevated, but you're better off to treat the ADHD to try to prevent the substance abuse in the future. So sometimes people get worried about that, but they have more financial problems. They don't manage their money well. They don't pay their bills on time. They get late fees, bankruptcies, things like that. They have more traffic accidents. They have more interpersonal problems, including divorce, and they have a higher risk of conduct disorder and criminality. So lots of things that can be negative in adulthood that we want to try to prevent if we can by helping them get treatment. You have to look at, is there something else going on, or just think about the differential, right? The kid may have a genetic disorder. They could have an intellectual disability that may look like trouble learning, right? So do we have to always look to see, is there intellectual disability? Is there Fragile X? Did this kid have a high risk factors for it? Did they exposed to tobacco or alcohol or drugs in utero? Did they have a birth trauma, hypoxia, low birth weight, prolonged labor? There's some question about forceps use and risk for ADHD. Have they been exposed to environmental toxins? Like even secondhand smoke can be kind of a risk for ADHD, and lead exposures. We can't do much about the genetics, the prenatal, the perinatal exposures. We could maybe do something about environmental exposures. We don't have a lot of lead poisoning here in Florida, so we don't see that very often, but other parts of the country, they might. Has the kid had a head injury? If you have had concussions or head injuries, that puts you at higher risk of having symptoms that are kind of like secondary ADHD that develop. About 20 to 25% of kids who have a significant head trauma will have something that looks like ADHD after that head trauma. Sleep apnea can mimic ADHD, so we're always looking for that in kids that snore. And obviously, if a kid comes in inattention or disruptive behaviors, they could have hearing or vision problems, right? So we're always screening for that kid that, has maybe partial hearing loss from repetitive, otitis media infections and PE tubes, that kind of thing. Or a kid, kids don't know their vision is blurry until they're old enough to be reading enough that people realize that they're holding the paper really closely or not seeing things correctly. So we're always looking for that stuff. Lots of psychiatric comorbidities. Half of kids with ADHD have oppositional defiant disorder. So half are just happy, hyper, or inattentive kids, but half are also going to push back, argue with you, give you a lot more trouble. About 40% have a learning disorder, so we're often looking to try to address that specifically. About a third will have conduct disorder, so they're lying, stealing, cheating, being aggressive. About a third have depression, about a third have anxiety, about a third have a developmental coordination disorder, and a small percent, like 10, have bipolar disorder. So lots of stuff that they could have going on. In terms of the neurobiology, like I said, it's highly heritable. On average, kids with ADHD have smaller brains that have more gray matter relative to controls. So that means their brain, and most of what we see is their brains are not myelinating as fast as controls. They tend to be behind on myelination by about 2 to 3 years. So a lot of times when parents say to me, like, we just went to a birthday party and all the other 8-year-olds were doing whatever it is. Why can't my kid do that? It's like, well, because your kid's brain is actually like a kid that was younger. So I sometimes tell parents or students the analogy that if I had a group of third graders and I was doing an art project and we were going to be using scissors and glue and glitter and whatever, and somebody walked a kindergartner in or a first grader into the room and said, hey, can this kid sit with you guys while you do this project? I would say, sure. And I would naturally, without even thinking about it, sit that kid next to me. I'd check in with them more often. I'd offer them some help. I would expect that they're going to be more clumsy, more messy, get the glitter on them, need help with the scissors. They're going to rush through it, be done, and be up and running around before the other kids. And then I might have to be like, hey, here's a job for you. Go around and get all the glitter, put the caps on, right? No problem. I'm going to do that naturally. But when the kid on the outside looks like all the other kids, then you're just mad at the kid. Like, what's wrong with you? Why are you doing this? Right. And so I often tell parents, you have to think and give your kid expectations at their brain's developmental age. So if you give them the 6-year-old directions when they're 8 years old and give them 6-year-old expectations, they'll be able to meet those expectations probably. And then that's frustrating in a group. So a lot of times parents are frustrated that their kid's not doing the same as the other kids in their group. But anyway, but they are myelinating more slowly. When does myelination get caught up? Around age 25 is when kids, most of us stop having brain myelination. So there's a long time where we can see improvements. We do actually see some smaller brain structures. The splenium of the corpus callosum is smaller. So the connections between two sides of the brain are smaller. The posterior inferior cerebellar vermis is smaller, which relates to timing deficits, and the right caudate nucleus, which relates to some of the hyperactivity. So we'll see all the executive function difficulties, trouble regulating themselves, trouble planning, trouble organizing, trouble shifting from one activity to another, trouble with impulse control. Like I said, poor sense of time, poor sequencing of activities, and they have this abnormal catecholamine metabolism. So lots of different things going on in their brains. This is from the NIH studies where they just looked at the normal brains. The purple is more myelinated, and you can see that kids just throughout childhood are having more and more myelination happen normally. And so there are some studies that show that if a kid is on stimulant medications, somehow it speeds the myelination back closer to control. So they do actually get better with the stimulant medicine. So how to make the diagnosis? We need multiple informants, right? You can use a standardized rating form like a Conners, ADHD-4, a Vanderbilt, a CBCL, lots of different ways. You just have to decide if you want one that's in the public domain, how you want to distribute that. Do you want one with norms, that kind of thing? How many questions you want to ask the family. The ADHD-4 is just 18 symptoms of ADHD, right? Whereas Vanderbilt has some for ODD, conduct, some for depression, anxiety, that kind of thing. You might get psychological testing, to get IQ and achievement testing, and that helps you rule out learning disorders or low IQ, but that's often hard to fund and hard to get a kid through the wait list for that. So we don't always do that right away, but we may do that if we feel like ADHD is not explaining all the difficulties a kid is having, or we feel like we're missing something. It could be psychological testing for autism or something else. So, all right. So first case, a 10-year-old girl is seen for her well child check, and her parents say she's having trouble in school. Teachers have observed her to appear distracted, or she's daydreaming a lot in class. Parents deny any hyperactivity. but say that she needs instructions to be repeated often, and the rating scales you give look like she could have ADHD. So what kind of treatment do you think you would start for a kid with ADHD? And I don't know how you guys like to do these things. If you want to unmute, if you want to put things in the chat, I don't know what would be better.
Let them have an opportunity. If you want to put your answer in the chat, that'd be great. What would you do with a 10-year-old girl?
Looks like she has ADHD.
ADHD, yeah.
Like inattentive ADHD.
Inattentive.
Anyone else playing along?
I threw an answer out there for you.
Yeah, Anzalini's going to start a long-acting methylphenidate. Anybody else?
As long as they can swallow a pill.
Yeah, exactly.
It's not with sprinklers. Yep.
No one else? Okay.
Right.
So it'll be more fun if you guys play along.
Come on, guys.
Obviously there are psychosocial treatments. Yeah, so we could talk about coping skills, maybe step-by-step skills, Vanderbilt. So certainly if you've done the rating skills, you could talk about what the treatment options are. So treatment options include parent management training. So you can teach parents, what the symptoms of ADHD are, how to manage behaviors. You can teach parents how to like structure kind of structure their house. So we talk to parents about emotion regulation. Like if I say that if you have 30 minutes before you're going to go to soccer practice and you asked your kid to clean the room. If your kid has ADHD, you can't walk away and come back in half an hour and be like, oh my God, what are you doing? You're not cleaning your room. Like you're playing with the toys, because you have to know that your kid is likely to get distracted and off task, and you have to circle back as a parent. It's hard if you're, God forbid, you're the parent who has the ADHD, right? That's hard. And you may have to help that parent too, or help them figure out how to get appropriate treatment. But they have to circle back to their kid in 5 minutes and be like, oh, are you cleaning your room? Looks like you're playing with your toys. Hey, why don't you stand up and like put that toy in the basket and like get started? So you're gonna have to so teaching parents about kind of mindful parenting, staying calm themselves, how to structure tasks. So the kid doesn't have to think through things, using a routine, all that kind of stuff. So you can do parent management training to help the parents structure their life. So some parents, it's just very chaotic and they expect the kid to, so we just need a routine, and often where incentives are after you've done the work. So after you've done your homework, that's when you get to play video games, not the other way around if it's hard to disconnect the kid from video games, right? So you can do parent management training. You certainly can have the kid get a 504 plan at school. Use a simple letter from one of us for 504. Social skills training sometimes helps if there's a lot of interpersonal difficulties, helping kids stop, listen, make conversation. For older teens and adults, you can do cognitive behavioral therapy. But that's not very helpful for young kids. Young kids they don't have enough brain development to really monitor themselves and reflect on, oh, I'm not meeting my goals or I'm not doing what I want. So you just need you need to structure the environment to help the younger kids. So definitely among these things, like with the 504 plan, might be a parent teacher daily journal, right? So kindergartners often do that. Kindergarten classrooms, first grade classrooms do this pretty well. Are you on red, green, yellow at school, or you have some kind of rating system? And when a kid gets a little older, sometimes you need to encourage the teacher and the parents to still have some kind of notebook that goes back and forth between the teacher and the parents that helps the two of them communicate. So mom can write, homework is in the left side of the green folder or whatever, and the teacher goes and gets it or whatever, helps the kid, So definitely, like somebody was saying, help to collaborate with school and home. So having the parent and teacher, have a daily report card of something. So, and then obviously you can use medications. There's stimulants and there's non-stimulants. And with any of this, you might use rating scales, the same rating scales you use to diagnose, to track improvement. So, how do stimulant medicines compare to behavioral treatment? So psychiatrists refer to this multimodal treatment study for ADHD, which was done in 1999. It was an NIH-funded study. There was 579 kids ages 7 to 11, and they got one of 4 treatment groups. They either did med management, which was monthly med management using methylphenidate immediate release because it was back in the 90s, or they did med management plus behavior treatment. That was combination treatment, or they did behavior treatment, or they just did their usual going to their primary care doctor or whatnot. The behavioral treatment was intensive treatment. It was parent training. It was teacher consultation, in-school observation by staff from the office. And there was a 6-week summer program where the kids went and did social skills group and summer programs, and all the kids had a therapist. Way more behavior support than I can ever get for a kid. So that was their behavior treatment arm, super intense behavior treatment arm. And the outcomes were that the combination treatment, the med management plus the behavior treatment, was exactly the same as the med management alone. So we mostly, because most of us even can't get that kind of behavioral management, we usually go with medication management, because both the combination and the med management were both better than the behavioral treatment alone. So you're better off to probably to start a medication, even though that's not always what parents want to hear. The average dose at the end of that study was the kids were on 30 milligrams of methylphenidate 3 times a day. That was how they ended up. That was before we had really long acting ones. The kids who went to usual care only went to see their primary care doctor twice a year, twice in the whole 14 months. It was a 14-month study. They only went twice during that 14 months, and they only filled 60 days worth of stimulant medicines. So they had the worst outcomes because they really just didn't follow up for whatever reason. Now, which kids benefited from the behavior treatment? The kids who were oppositional or had conduct disorder or had a lot of anxiety. So if you're thinking about which kids need to go to behavior treatment, it's the anxious kids and the oppositional or conduct disorder kids. So sometimes parents are like, well, I think I want my kid to go to treatment too. And if they just have plain ADHD with no comorbidity, not really worth anybody's time. The parent needs to be doing everything really to help. It's really just structuring the environment when the kids are little. So medicines for ADHD, we've got the 2 stimulants, amphetamine category or methylphenidate category. And then you've got your non-stimulants. You've got your selective norepinephrine reuptake inhibitors like atomoxetine or viloxazine, that's Strattera and Qelbree. You've got your alpha-2 agonists, clonidine and guanfacine, which the long-actings are Intuniv and Cat-Bay, right? You could use off-label, you could use bupropion. Off-label, you could use a tricyclic antidepressant. It's kind of our treatment algorithms. So how you choose a medicine? Well, some of it is, where is the kid having trouble? Is the kid having trouble just at school? Or is it more problematic at home at night with their siblings and the dog and that kind of thing? So what part of the day are they having the most difficulty with? Is it more family life or more school life that's more impacted, or kind of equal across the board? What's their insurance, like kind of formulary? So like along with where they're having trouble, how long do we want treatment for? Sometimes I've got a high school kid who's just doing like FLVS and they're only really studying for 3 to 4 hours, and their biggest difficulty is just their schoolwork concentration. They're doing okay managing their laundry and their other stuff in life, and they just want 3 to 4 hours worth of help. Can the kids swallow pills like Dr. Anzalone said? Absolutely. What time is this kid's bedtime? What time is dinner? The younger the kid is, the more I need to know how is family life structured. I can't give them a medicine that they're eating dinner at 5 o'clock that hasn't worn out of their system by 5 o'clock. So do they have any comorbidities I need to worry about as far as anxiety, tics, depression, anything like that? Any side effects we're really concerned about? Is this a kid who we really can't tolerate any weight loss? All those kind of questions. So it's never just like, what do I start with? There's a whole bunch of considerations. I would say that, and this, well, I'll just say it in here somewhere. I'll tell you in a minute. So stimulants, increase, they really all increase norepinephrine, and then some directly increase dopamine. The amphetamines directly increase dopamine. The methylphenidates secondarily increase dopamine, and they usually decrease the reuptake of dopamine and norepinephrine. So that addresses kind of all the symptom domains of ADHD. The effect size for stimulants is very large. It's somewhere between 0.8 and 1. If you look at the various studies. If you take kids with ADHD and give 80% of them, if you give them methylphenidate, 80% will respond to methylphenidate. If you take those same kids and you give them all amphetamine, 80% will respond to amphetamine. And when you look at both the methylphenidate and amphetamine, 90% of people will respond to one or the other of those. We've got 10% of kids that don't respond to a stimulant, more kids that respond to the stimulant but have trouble side effects and tolerating. That's a bigger category. So on the Medicaid PDL, preferred drug list, For the immediate release ones, you've got methylphenidate and dexmethylphenidate. You've got tablets and liquids. Intermediate ones, I'm assuming you guys mostly see kids with Medicaid, is that right? Is that the majority? Maybe.
Majority.
Okay, so on Medicaid intermediate 6 to 8 hours, you've got Metadate ER, which is 50% of the medicine now, 50% of the medicine in 4 hours. You've got Metadate CD, which is technically 30% of the dose of the medicine now and 70% in 4 hours. So it's shifted a little bit later. Focal XR is 50% now, 50% in 4 hours, and that is twice as potent as methylphenidate, right? So the dose is half. So 20 milligrams of methylphenidate ER is 10 of the dexmethylphenidate, the focal and XR. And you've got some long actings that are more like supposed to be 10 to 12 hours. So you've got Concerta, Daytrona, and Jornay PM. Concerta, the original Concerta, the brand name, is a plastic pill that has a hole drilled in it, has a sponge inside, and when the pill gets swallowed, you absorb liquids from your GI tract, and slowly the little sponge inside expands and pushes the medicine out of the pill. So it kind of slow releases across the GI tract. There was a 22% of the dose was an overcoat that immediately dissolved when they took the medication. Most of the generics are not actually formulated that way. They use some kind of long-acting preparation, and so the generics are highly variable as to how well they act for each person because they're not that same exact form. They're mostly not equivalent to Concerta. On the other hand, they're often good enough for most kids. Daytrona is a patch that you put on. It takes 1 to 2 hours to absorb in the system. It slowly absorbs through the skin. So a lot of kids who you give a Daytrona patch to need an immediate release stimulant in the morning to take right when they get up and they put the patch on. Or some parents get up, and if their kid is a pretty good sleeper, they may get up at 5 o'clock in the morning, put the patch on the kid, go about getting themselves ready, get the kid out of bed, an hour and a half, 2 hours later when the medicine's in their system. So with Daytrona, you have to often figure out that initial morning plan. Versus Jornay PM is a long-acting methylphenidate that you take at night, and it has this delayed release technology that you take it around 8 to 9 o'clock at night, and it slow releases. It starts to bring your blood level up around 5 or 6 a.m. So kids have the medicine in their body when they wake up. So that's to help really manage the morning symptoms. These ones, so you can crush methylphenidate and dexmethylphenidate. You should not crush the Metadate ER, CD, or Concerta. You can open and sprinkle the Metadate CD, the focal and XR, or the Jornay PM. So you've got options there. If you have a kid who you want to crush medicines, you want to open and sprinkle it. Some kids don't like the texture of the bead. So if a kid can't swallow, I want to know, will they take something that they will open and sprinkle on like applesauce? Some kids are going to crunch up every single little bead, and that's not going to help. But if they'll kind of swallow it, then you can use a sprinkleable one. Versus, do they need a chewable? Do they need a liquid? Then when they want to argue about flavors, they don't have a lot of control over the flavor, but amphetamine preparations on the Medicaid PDL. Remember, the amphetamine doses are twice as much as the methylphenidate doses, equivalent to the dexmethylphenidate doses. So short acting, you've got dextroamphetamine, and you've got the dextroamphetamine amphetamine, which is Adderall. So Adderall is technically a mixture of 4 different amphetamine and dextroamphetamine salts. So it's 75% dextroamphetamine and 25% L-amphetamine. It doesn't matter a whole lot, but it is technically different than just straight up dextroamphetamine. You've got extended release. You've got 8 to 12 hours. You've got Adderall XR, and you've got Vyvanse. Vyvanse, is a Vyvanse is a capsule. Inside that capsule is, we'll get to the next one, is a powder. So those are both closer to like 12 hours. Vyvanse is a prodrug, right? So it doesn't do anything until you swallow it, and it's activated by by cleaving off. I think it's a cysteine. It's a lysine. I think it's a lysine on it, and you just cleave off the lysine. So you need to have stomach acid. So it's not the best one for a kid who's on like PPIs chronically or H2 blockers chronically or often, because you do need it to be activated in the stomach. And so you can crush the short actings. You can open and sprinkle Adderall XR. You can open Vyvanse and you can mix it in water. It's a powder. It gets dissolved. This is really nice if you've got a sophisticated enough family that they can vary the dose. So I might give them a dose, so Vyvanse is one, I can give a higher dose than I want, then I think they're gonna, if I say, okay, I think you might need 40, but I don't want you to start on that. I can have you open it up, mix it in water, give the kid half of whatever you've mixed, right? So you tell the parent, take a cup of water, open the pill, dissolve it in there, and give them half of the cup of water to drink. They didn't study it to see if it's shelf stable later or the next day or anything like that. So we don't know. We usually just tell people to discard whatever they don't use. But that also means families can adjust the dose a little bit to find the right dose without having to have multiple doses of pills. So the immediate release pills last only 3 to 4 hours, so that often requires twice or 3 times a day dosing. Whereas you've got the longer acting ones can last up to 12 hours, like Concerta, Daytrana, Medeus, which isn't on the Medicaid formulary, Vyvanse. A lot of people like a long acting because it preserves some privacy. You don't have to tell the school and all the other kids and your teachers and everybody that you're on medicine, right? So we usually, when I was training initially in the 90s, we gave everybody immediate release doses of medicines. But nowadays, it's more standard for us to start with a long acting. So the parents are in control of that just at home. And then you go from there and figure out what you need. Do you need a little bit more at the end of the day? Do you need a longer acting preparation at the end of the day? Or do you need to add a short acting to help with homework if it's not lasting long enough? Or vice versa, do we need short acting in the morning because something's not kicking in until later? The long actings often give a smoother delivery of medication. So there's those things. Drug holidays are not required, but are okay. Depends on the kid and the family. Drug holidays, like taking breaks from the medication, do help kids get caught up on weight, not as good at helping kids get caught up on height. So a little bit of information here. So some side effects with stimulants include, insomnia, decreased appetite, weight loss, failure to make weight gains. Interesting enough, upper abdominal pain is listed for a lot of stimulants. This is not really listed in the package insert, but we see that lots of kids get moody or have increased anger. We often want to know, is it like all day long the kid is crying? Some kids are just crying and emotional. Some kids, they have where it's when it wears off. They've got like an hour or two that parents will say is like the witching hour where they're all hangry and hungry and angry and upset, and then it all settles down. So do we just need to manage that hour or so better? And there's different strategies for that, or they just upset all day long or more aggressive all day long. They could have tics, they can have compulsive skin picking or hair pulling, and obviously they can have an increase in blood pressure or increase in pulse. The average is 4 millimeters of mercury systolic blood pressure, but and an average of 4 beats per minute on the pulse, but the range is really wide. You can see an increase in pulse by 30 beats per minute or increase in systolic blood pressure of 30 millimeters of mercury. So you just want to catch those. And thinking about cardiac effects. Do you guys tend to get any kind of EKG or do any kind of specific cardiac screening or anything before you start?
No, questionnaire, just ask questions if there's any history of any arrhythmias in the family, if there's, prolonged QT, those kinds of things that you'd worry about. But for the most part, I don't think it's a standard to do EKGs at this point.
Yeah, I document that I ask the questions as well. So
yeah,
exactly. Yeah. Okay, so we usually do is just document that we've asked some questions. So kids can go up to there was a question in the chat about can the kid go up to school? So yeah, a kid could take medications at school. Kind of just depends on if the family wants to do that. There's a little bit of can they transport the medication to school? Some parents don't trust the specific staff that the schools have. Schools don't have nurses these days, so it's usually a specific person in the office that's giving their kids their medicine, and they may feel like that staff person's not watching the kids well enough. So, because there are certainly times when kids get their medicine, turn around, hand it to the kid behind them in line, or don't actually take it. So sometimes they don't feel that the nursing staff or the office staff is watching the kid take the medication. Sometimes the other kids don't want to go up to the office because they're it takes away from time at lunch with my friends, or the other kids now know that I'm going to the office for some reason that they figure out as a medicine. So that kind of depends on whether families can manage that and how they feel about the school. We usually ask if the kid has any personal cardiac history themselves. So does the kid have any personal cardiac history? We might ask if they've had seizures or syncope. And we'll ask for a family history of anybody under age 40 that had sudden cardiac death or an unexplained death, like a drowning or like, exercising and dying, right? We're looking for hypertrophy. We're looking for HOCM that isn't apparent yet, right? That we're looking for or a long QTC syndrome. In Europe, when you do a school physical in Europe, they do after age 12, they do an EKG because they're looking for HOCM, whereas we don't do that in this country. So a lot of times I'm just kind of screening, like, especially if even if a kid's been on a stimulant for a long time, when they get to puberty, I might ask again, do we have anybody in the family that's had if I don't see it documented, maybe I inherited the kid or something, I want to make sure we've documented, has there been any unexplained deaths at a young age in the family from a cardiac reason? Ideally the kid, you perform a physical exam, and usually you only get an EKG or a cardiac evaluation if there's something, of concern in the family or the kid's history, right? You're going to get
Dr. Stock,
Yeah.
I have a question for you. So, a number of years ago with structural hearts, like I had a kid with transposition, obviously some bradycardia. It was amazing that the stimulant medicine actually helped the child, and the cardiologist, I've never had a cardiologist say, don't give the kid a stimulant. It's just,
Probably true.
as many times I've referred, I've not had one other than obviously arrhythmias, but for structural hearts, I've not had anybody say, don't use a stimulant.
Yeah, I'd say the same thing. We've had kids with tetralogy flow, kids who have transposition of the vessels. I have kids with, so I have had occasionally, I had one kid who had a really calcified aortic valve that the cardiologist told me they wanted me to use as low of a dose as I could. And we had one kid where they were having a lot of just like a lot of fatigue with exercise, like shortness of breath with exercise, and they wanted them to get an echo, and the family didn't want to. So then the cardiologist said, "Then I'm not going to clear you," right? Makes sense. But they were just concerned about that. So, but I would agree with you that it's very rare that the cardiologist says no. But I think it's better to make sure that we've gotten as much cardiac history, like we've got clarity on what the issues are before they take the stimulant, right? Just from a medical legal standpoint, as well as just do they need to be watched for anything else, because I've got kids with got other kids with like mitral regurg or like aortic regurg or different things that they are needing other medicines to help manage symptoms. So,
or how about sympathy after they started the medication? You're like, okay, work up.
Also, we usually ask before at baseline about any cardiac history in the kid or the family. Yeah. And then sometimes the things emerge when they're taking the medicine. There's times when we'll refuse to give a medicine until they've seen the cardiologist. We're like, no, you can't have this anymore. You're gonna have to figure out how to live without it. But we do get, baseline weight, height, blood pressure, pulse for monitoring, right? So, all right. So this kiddo, this 10-year-old girl, and she's having trouble in school. We think she has ADHD. What if her parents don't want to start a non-stimulant, or don't want to start a stimulant? What medicines would you guys consider? What do you feel? What do you usually do for an inattentive kid? Same girl, she was inattentive, and they don't want to start a stimulant. What would you do?
Often do Intuitive if they can swallow a pill, or guanfacine if they can't.
Could do that. Anybody else? So we think about guanfacine. I do tend to use the when I'm using alpha 2s, I do tend to use guanfacine first, just because it's a little longer acting. So I would say that most of us, so the studies with alpha 2 agonists would say that they work for inattention and hyperactivity, all the symptoms. I would say most of us feel like it works better in the hyperactive impulsive domain. So typically for an inattentive kid, if they don't want to take a stimulant or can't tolerate it, I would usually go with a selective norepinephrine reuptake inhibitor like atomoxetine, which is Strattera. These have the advantage that they're, if it's a non-stimulant, they have the advantage that they're not a controlled substance. You can send in refills. Atomoxetine is FDA approved in all ages, adults, teens, and kids down to age 6. It's got a lower effect size, like 0.06. I usually start with 0.5 milligrams per kilogram per day just to help with tolerability. Do that for 1 week and then go to the target dose, which is 1 milligram per kilogram per day. So stimulants, psychiatrists don't dose the stimulants based on weight. We just start at a low dose and work up to effect. But atomoxetine, you do want to go your target dose based on their weight. And because they have compared the different doses, and definitely 1 milligram per kilogram is a good target dose. That works better than the 0.5 milligram per kilo. The max that was FDA approved was 1.4 milligrams per kilogram per day. But the studies all did half, 1, and 1.8 milligrams per kilogram. So I'll even go up to 1.8 because that's what the studies were. And it does work at all the symptom domains. And a lot of times when I have like girls who the stimulants work, inattentive girls, the stimulants work, then they lose weight or they get irritable or they can't sleep. And we just keep doing this thing where we're like putting them on a stimulant, it works for a while, then they don't like it and they go off of it. We're on and off of it over the years. Often atomoxetine works well. Downsides atomoxetine, 25% of kids, 20-25% get nausea. Nausea is your biggest problem. You can also get headache, sedation. It can increase systolic blood pressure. It can increase heart rate still. You can give it any time of the day. It doesn't matter what time of the day you give it. You can even give it twice a day. I usually I heard this tip a few years ago, and I think it works well. Start it with dinner the first 2 weeks. You take it with your largest meal of the day for the first 2 weeks. You have better tolerability, less of that nausea, and then you can move it any time of the day that you want. There was these reports about liver failure, and there was like 11 kids that got liver failure, and they said like if a kid did, but it's so rare that they didn't recommend liver function tests on any regular basis, just if they have abdominal pain that's unexplained, get LFTs. But then no other kids, that was like more than 10 years ago, 15 years ago, and no more kids have had liver failure since then. So nobody knows what happened with that like time frame where there was 11 kids with liver failure. Atomoxetine, being that it increases norepinephrine, it's similar, like that's what bupropion does. So it gets lumped under this black box warning that all things that look antidepressant-ish they have this risk of suicidal thoughts. We didn't see that in any studies, but that gets lumped in that just like bupropion or other antidepressants. So that's on the package insert for parents to know. Viloxazine is pretty similar in that it's a selective norepinephrine reuptake inhibitor. The effect size is 0.5 to 0.6. Big advantage is it can be sprinkled, opened and sprinkled, way less trouble with nausea. Problem with this one is sedation and fatigue. You can use it if the kid has Medicaid. They have to have failed 2 other ADHD medicines, which can even be guanfacine. So if the kid is ages 6 to 11, you start at 100 milligrams per day. You titrate up 100 milligrams per week up to 400. If they're 12 or higher, you start at 200 and then titrate up to towards 400. So again, sedation, fatigue, low appetite, nausea, irritability, those are your side effects. But really what we've seen more is that sometimes kids are just too sleepy on this one. And then, this is switching cases. So I would probably use a selective norepinephrine reuptake inhibitor if the kid was inattentive. So it's another case, a case who's a 9-year-old male presenting with ADHD symptoms that are becoming more impairing. He's got a 504 plan at school. Parents are interested in starting medicine, and he does have intermittent tics. So what medicines do you start when a kid has tics? Some people are laughing. Anybody else, feel free to turn your cameras on or talk. Should have made you guys all turn your cameras on to start with.
I want to go with intuitive again, but I don't want to be wrong.
Anybody want to give it a different opinion? Natalie, Tanya, Susan, Richard, Abigail, Helena, you guys got any different opinions? Jose, Maureen, Marga?
That's Dr. Puel. Dr. Puel. Where are you? Are you on? You were on.
Yeah, I still use stimulants. I start at a low dose and see if they're worsened or not.
Yeah, so I think either one of you would be right. 50% of the time the tics get worse with the stimulant. So stimulants can still be used, even with kids with Tourette's. So they did the Tourette Syndrome Association. There's this triad with kids who have tics, have Tourette syndrome and ADHD and OCD. Lots of kids with Tourette syndrome have ADHD. So the Tourette Syndrome Association helped sponsor study, help look at studies. And so half of the time kids' tics get worse. So whereas with an alpha-2 agonist, about 30% of the time the tics actually improve. So it kind of depends. You may talk to a family and say, like, do you want to take the risk of you want to try a stimulant because it works really, really well for the focus and perhaps hyperactivity might make tics worse? Or do you want to try something that is likely to help the hyperactivity, impulsivity, might help the focus, might help the tics? Like, so, I'd say that guanfacine and clonidine are just a little less robust for the focus. And some families will say, no, we don't want to take any risk of the tics getting any worse. Tics are a big part of the problem, or hyperactivity is a big part of the problem. So we'll go with the alpha 2, or maybe they want to try stimulant because they really want that help in the focus. So kind of depends. And you can also talk to them about habit reversal therapy or the comprehensive behavioral intervention for tics, which is called CBITS, if you have access to that, if you have any behavioral treatments. So your alpha 2 agonists, the short acting, are clonidine and guanfacine. So the 10X is the brand name of the short acting guanfacine. There's no studies with ADHD of the short actings. We use them all the time. It's fine, but there's no studies with them. If I use guanfacine short acting, the 10X, I use it twice a day because it seems to only work for about 12 hours, if that. Clonidine short acting sometimes needs to be dosed every 4 hours like a short acting stimulant. So you may end up on that for TID or QID dosing. So that one can be hard. And you can have some rebound hypertension and some rebound behavior when it wears off. So we tend to use the long acting more often. So guanfacine XR, brand name Intuniv, clonidine XR, brand name Catve. Those are studied for ADHD. They're FDA approved to treat ADHD. They're even FDA approved to use in combination with the stimulant. Like one of the few times that we have combination treatment actually FDA approved. So we use these all the time. And for those like nonverbal kids with autism who are just super hyper, very neurologically impaired, we might use a catapress patch even. That's off-label. So like I said, there's only a handful of studies for the short actings. They work centrally on alpha 2 receptors, simulating they're binding to those norepinephrine alpha 2 receptors. They're kind of simulating a sympathetic nervous system response. Again, we think they're better for hyperactivity. But the short acting ones, a lot of kids are sedated, especially with clonidine. So we can use clonidine for sleep. It's very hard to take it during the daytime. So the guanfacine only comes as 1 milligram tablets. So it's very crumbly. It's hard to cut in half. It's almost impossible to quarter. So be careful with it. If we usually start at 0.5 milligram at night. We might titrate up. Usually the maximum will be like 4 milligrams in a day. Clonidine 0.1 tablets or the patch. Again, you might start it with a half and titrate it up. But if you're trying to use immediate release clonidine for ADHD across the day, you got to use it multiple times a day. You can use it just at night to sleep if you want. So the long-acting guanfacine's approved ages 6 to 17, monotherapy or add-on. Again, it's stimulating those alpha 2 receptors. Study said effect size of 0.7. Takes about 2 weeks to work. It doesn't work as immediately. Stimulants are attractive to parents because they work the same day. Side effects: sedation, dizziness, headache, and it has like a dose range, like a milligram per kilogram, and we stick to the max dose of this, max dosing of 0.12 milligrams per kilograms per day. We usually don't change the dose more than 1 milligram, per day, like in a given week. So we titrate up and we titrate down. And the clonidine XR, I don't use as often, partly because it's not on the Medicaid PDL. So that makes it harder. You can use the guanfacine XR, but not the clonidine XR, unless you've maybe been on a bunch of other medicines. So pretty similar, stimulates alpha 2 receptors, effect size is 0.7, takes a few weeks to work, same kind of side effects: sedation, headache, dizziness, and we change it by, 1 tab, per week. So let's see. So that's kind of a summary. The ADHD is the most common neurobehavioral disorder in childhood, right? So in childhood, elementary school, it's the most common thing. Anxiety, depression, bipolar disorder, autism, all these things are less common than ADHD in the elementary school age. By the time you get to adulthood, or like even middle school, high school, but certainly by the time you get to high school, things are reversing around. Depression and anxiety are more common than ADHD. So, what we're thinking of in terms of diagnosis changes based on what's most prevalent in that age group, right? There's definite neurobiological underpinnings and long-term sequelae that reach into adulthood. Kids do improve. We used to say that kids grew out of the hyperactivity around puberty. They do usually grow out of the overtly running all over, but they tend to still be fidgety, wiggly, can't sit through a movie, stuff that's they're restless. Stimulants are the most effective intervention. That doesn't mean it's the only intervention, but it tends to be the most effective. And then you also want to have some behavioral interventions like, a 504 plan at school, extra time on tests, maybe a tutor, helping them learn organizational skills. I have different times when I will talk, like in fifth grade, I tend to talk to kids and families about, like, when I have my spring appointment with kids in fifth grade, I'll talk to them about in the summer. I want them to work on using a calendar. I want them to write down every fun event they're going to go to, the beach, a friend's house, grandma's. They got to write down their chores, write down anything they have to go to, like mom's dentist appointment. I want the family to start using a calendar or agenda and checking it. And I'll tell them if they're going to the beach or on vacation, I want them to write a list of everything they're going to pack and cross it off. And I want the kid to do the writing it on the paper to try to help them begin to think about organizational skills and lists. Same, if they're really still terrible at that, I might talk about that in eighth grade as well. But like I said, stimulant meds are the most effective and to watch for. So I don't know how long you guys have. So anybody have questions you want to put in the chat, or you want to unmute and ask some other questions? I'm happy to answer some.
I think we can try to, if we can have some questions. Anybody have any questions they want to ask?
Requests for scenarios to talk about next time, and you can call the pediatric hotline to talk with me or other psychiatrists.
I think the hotline.
Actually, I have a question.
Yeah.
Go ahead, Risha.
Yeah.
Dr. Brown.
Hi. Yeah. I was just speaking with a colleague. Lots of patients with autism, ADHD, use of risperidone rather than ADHD meds. If maybe the next time we could talk about that too.
Okay.
Yeah.
Using the risperidone for the ADHD or using it for comorbid aggression?
Comorbid aggression, but instead of also adding on an ADHD med, sort of using that and maybe an antidepressant or anti-psych.
Mm-hmm.
I've used stimulants and risperidone sometimes in those kiddos. And Dr. Stock, even the long-acting guanfacine for those kids who can swallow a pill that have autism and ADHD, somehow or another that particular medication seems to hit a little bit of the aggression as well as the hyperactivity for some reason. I don't know if that's just anecdotal or if you have anything that you might want to add to that.
The guanfacine or risperidone?
Intuitive. I've used Intuitive for the hyperactivity. And it seems like the aggression or the impulsive aggression settles down to a point where it's tolerable.
That's largely we would see that as largely being part of the hyperactive symptoms getting better, not the hyperactive, but the impulsive symptoms, right? So a lot of using guanfacine because the kid's frustration tolerance improves. So they're not as likely to get frustrated. They do better with waiting. So, trouble waiting, like those kind of things, like poor impulse control, trouble waiting their turn, trouble waiting in line, trouble interrupting other people. That all gets better with guanfacine. And so then the aggression goes down because they're less frustrated.
Right. So I've used that first and then risperidone if I have to. So.
I could give you the short answer is your aggression algorithm is stimulant plus non-stimulant. Then you can go on to risperidone, typically. I will say that with the risperidone and autism, it does help hyperactivity a little bit. They did see that in the studies, in the REP studies. So sometimes that's the case, but I would say typically, with autism, it's could be a little bit different, but typically if you've got a kid with ADHD, ODD, or ADHD conduct, stimulant plus non-stimulant, then move on to something else, which might be risperidone, might be Abilify, might be Depakote. That's the short answer.
Can I ask something?
Yeah.
That's Dr. DeVera. How are you, Adele?
I'm good. Yeah. So how imperative is it to do a follow-up rating scale, and when do we do it? Because especially if you see improvement, we'll normally do a follow-up rating. Yeah. Mm-hmm.
Yeah. I mean, the guidelines really say you really should do rating scales for diagnosis. Lots of people do rating scales to kind of decide how much is improved. I think, but there's no real clear, like you could do it when you think you're like at a good point, like if you feel like, okay, I think that we've gotten everything covered and we just want to make sure we're asking the teacher if we're missing anything. I think you also have to be careful about, not, you don't necessarily want to frustrate teachers a ton. I think I usually do follow-up rating scales when it feels like we're not sure if there's been improvement or I'm getting different opinions about improvement between mom and dad. I might say, okay, you guys each take a rating scale, no talking, fill it out. Let me see, or maybe I'll, mom saying nothing's improved and the teacher saying things, or vice versa. Mom says things are better, but the teacher doesn't think so. Then I might get more information, So, but there's no real great, I think you could just, you could do a rating scale, like when you feel like you've kind of gotten to a spot where you're either need to make a big change in treatment, or you're trying to decide, is this ADHD or is this something else that's driving it? Then you might have them do a rating scale to be like, okay, it looks like it's not really ADHD. It's probably more mood or more anxiety or more something else. I think that's usually when we would do it.
Okay, thank you.
Yeah. And I usually, if I'm just want those symptoms, I go with a shorter and shorter rating scale to try not to frustrate everybody with a long rating scale. So the ADHD 4 is the shortest one.
Dr. Stock, I think your next month we're going to be talking about maybe even under 6 months, under 6 years of age, what to do with kids by 4 to 6, and some older kids. I think that was part of your slides, if I'm not mistaken.
Yeah.
Um,
And
yeah,
once we can take
yeah,
suggestions, if people want to give
yeah,
you suggestions about what other kind of topics they like. So
yeah.
we were going to talk about like preschoolers, maybe adolescents with comorbid depression or questionable depression, that kind of thing.
Right.
We can talk about the autism kind of thing.
Could I
Yeah.
ask one other question? This is Dr. Brown again. Do you know of any studies that have been done, ADHD related, and effect of taking them out of like a group setting, like a public school or private school, and how they do in kind of more of a one-on-one school, like a home school or a smaller environment or a virtual school? Because I had a parent ask me that question,
Mhm.
and she's done that, and she seems to find
Mhm.
benefit, but I was just curious, has there been any studies?
I doubt there's been any studies of it. I mean, what we know is that kids with ADHD do better with one-on-one instruction, right? So lots of kids, parents, they do fine with, like, if the mom sits there and says, okay, do problem number 1, great. Now do problem number 2, great. Now do problem number 3, great. Now, if mom sits there with them, they'll do their work, but they don't do it well on their own. Lots of kids do better if there's one person there coaching them. Wait, say that again. Wait, so that it helps modulate the frustration or answer the questions in real time, because kids with ADHD often can't wait to get their question answered or even remember what they wanted to ask or articulate what they want to ask. They don't always know what their question is, but if you're working with them one-on-one, you can figure it out. So I'll tell you, the pandemic was amazing for this, because everybody got put into virtual school immediately, right? And some of my very worst patients with ADHD were doing phenomenally in virtual school. And some kids I thought would be flourishing were doing horrible. So I would say it really is quite variable. Almost everybody will do better in a smaller setting with one-on-one teaching or tutoring. But when it comes to the virtual school, some kids are bright and motivated enough that they will just run through the material. They are so motivated to get it done and get outside and go fishing or go play with their dog or go paint or do whatever. If a kid who has like high level of, they're smart, but they have a lot of other interests, they'll do fabulously in virtual school. Other kids won't ever do the work, and it turns into 24/7 mom trying to cajole the kid into doing work, and everybody's more than miserable than they were before. So some kids need to stay in the brick and mortar, and virtual is not. I mean, I've got some college kids where I'm like, you cannot take a virtual class, or they'll be like, I'm gonna have to up my meds because I've got a virtual class, and I can't do that. Like that, and so it's really individual, and it helps to talk to the kid and family about like how well do they do on their own on subjects that they like. If they're a kid who's going to spend all day learning about turtles because they love it, they love that, and they really can do good quality work, but they just can't tolerate the structure of school, they'll do fine. But not everybody realizes that about their kids. So, and if they do virtual school, then we usually insist that they be any kid, homeschool, virtual school. We usually insist that they're in one group activity with kids their same age throughout the week. So, like if you're gonna have your kid in homeschool, I want them in karate or football team or an art class or horseback riding or something.
That's awesome. Dr. Stock, thank you. Our time is up for the session, but I appreciate you coming out. We're looking forward to next month and continued education on what you provided us. I think it's wonderful, and I hope everyone enjoyed. And at the end will be a survey for those of you who will go through that with you. And thank goodness this is recorded. It was excellent. I really appreciate you being here today.
Absolutely. And we'll talk to some of you guys before next month.
Thank you.
Great job. Thanks.